Biofilm communities can be viewed as pure, and that is that they are all descendants of a Borrelia spiral form that became a granular form and then a liposomal form, and it's all Borrelia DNA in the matrix, and there's only one DNA family. Or they can be classified as mixed type biofilms, and mixed biofilms are what we see in nature. And other infectious organisms, such as Babesia, are welcome in Borrelia biofilms, but we have not proven that they are in Borrelia biofilms because we haven't had the right tissues to test. There is no reason why we can't have mixed infection Borrelia biofilms with Coxiella burnetii and with Anaplasma phagocytophilum and with the Ehrlichias and with the Bartonellas. There is no reason why we can't have mixed biofilms. That is what is in nature. That is expected. That's not exceptional. So it's expected. And they're all served by the protective mechanism. They're all in a safe niche, and they're all going to be chronic and hard to get rid of. And Herxheimer reactions happen during the treatment of Lyme borreliosis with various therapies. And one of the interesting things is that the patients sometimes will describe that 3 years ago they had the tick bite, they had the rash, the erythema, and now I have the antibiotic and I've got a Herxheimer reaction, and we call it Herxine, Herx for short. I'm Herxine and I see that my erythema has come back at the site where I had my tick bite, or the erythema that I had on my original tick bite site is now moved over to my belly and it's red hot, and then it goes away. So Herxine can produce skin reactions, it can produce headache, it can produce blood pressure and other muscle pain, joint reactions. Killing off the other bugs can also produce some sort of a Herx reaction, Herxheimer reaction. So busting the biofilms open and allowing these things to be exposed to killing agents could have side effects, and they could be Herx-like side effects. Now, there are cases on record where patients diagnosed with good laboratory technique in Europe while on antibiotic therapy have died on the first week of therapy for the following reason. Their intestines shut down, and they went into what's called ileus, and then they had infection from all of the bacteria that normally are contained within the gut, and they got into the bloodstream, and they got sepsis, and they died suddenly during antibiotic therapy for Borrelia infection. Why should this happen? Well, I don't know, but I know that descriptively it is a recognized complication of therapy, that sometimes there will be a fatal outcome, not because the therapy wasn't doing its job, but because the patient couldn't survive all of the consequences of dead bacteria being dumped into their system. Now, medicine has a phrase, and it's used all the time in cancer therapy, and it's a very bad phrase. And I'm going to talk about this in terms which I hope are not too angry, but I am angry about this term. Doctors will say, particularly in cancer therapy, the patient failed therapy, when what they should say is the therapy failed the patient, all right? But in shorthand, because doctors speak in shorthand, you know, and on day 31, patient failed therapy and went downhill and died, all right? Patient didn't fail. Therapy failed the patient. The doctor supervising the therapy failed to keep close enough tabs on the patient to support the patient through a difficult time, and all bad things happened, and then the patient died. So patient failed therapy means that the therapy failed the patient, and maybe the doctor also failed the patient. There are various ways that you can die. You can die of heart failure. you can die of lung failure. You can die of liver failure. You can die of kidney failure. And unfortunately, you can die of physician failure. And we as physicians have to be aware that we have an obligation to the patient to keep tabs on them and to not send them out the door with a prescription and say, I'll see you in 3 months. Particularly if the therapy has the potential to cause a lot of trouble, like Herxine can cause a lot of trouble. You have to stay in touch with your patients, and sometimes you have to hospitalize them, and the insurance company has to pay a fee so that the patients can be monitored around the clock while they're going through difficult moments in their therapy. Patients don't fail therapy. Therapy fails patients. Lyme disease was born in the 80s, and Lyme disease was coined as a term by Alan Steer, who is a rheumatologist and a professor at the Massachusetts General Hospital, Harvard Medical School. And Lyme disease was his name. Now, he was alerted to this by Polly Murray and Judith Mensch, and they called him to investigate the rheumatoid arthritis, juvenile rheumatoid arthritis in Lyme, Connecticut. And he investigated it, and then he wrote papers, and he discovered the arthritis, and that he was very interested in the knee. Then he discovered the EKG abnormalities. Then he discovered the meningitis abnormalities. He discovered the facial droop, the facial palsy, Bell's palsy form. And finally, he got around to getting in contact with the skin manifestation. Doctors in Groton, Connecticut were way ahead of Alan Steer. They had recognized the erythema in the skin even before Willy Bergdorfer discovered the spirochete, and they decided to treat it with antibiotics. And Alan Steer wrote an article in 1979 in Hospital Practice and said, you know, there are some people who give antibiotics for this, but I really don't think it's necessary. And that was a swipe at the physicians in Groton, Connecticut, who were right on and who were ahead of Alan Steer in recognizing that antibiotics did benefit patients with Lyme disease. Now, there are 4 points on the Steer compass to Lyme disease. The joint manifestation, number 1, that's north. The heart manifestation, that's east. The meningitis manifestation, that's south, right? And the skin manifestation, that's west. So if you're using the Steer compass to navigate over Lyme disease territory, you have 4 points on your compass. You don't have blindness, but unfortunately Lyme disease can cause blindness. That's not on the Steer compass. You don't have lung failure and death. That's not on the Steer compass. You don't have dead babies due to infection of the unborn in the uterus. That's ironically not on the Steer compass, but he wrote and was one of the co-authors of the first report of a baby that died in the first 39 hours after birth of Lyme disease acquired while in the uterus. So all of this has gone beyond and outgrown Lyme. And Europeans don't want to call it Lyme because there's no Lyme in Europe, there's no Lyme in Connecticut, it's Borrelia. So borreliosis is a better terminology. And finally, we have Miyamotoi, don't we? And Miyamotoi is not even in the Borrelia burgdorferi family, it's in the relapsing fever family. But it can cause aseptic meningitis and encephalomyelitis, and it's transmitted by the same tick that causes the Lyme disease infection. And so now we have borreliosis, relapsing fever type, Miyamotoi, Borrelia burgdorferi family type, and that's all of the ones we mentioned, coming together into a complex. And they are right when they say it should be borreliosis. Now, the multiple co-infections, Rich Horowitz, who's a doctor in Westchester, talks about the multiple infection disease syndrome, and that's a good terminology. It's scientifically correct. It won't fly, I don't think, because it doesn't have a commercial, flavor to it. I think it's too scientific for most people. They want to have a short term. They don't want to have a long term. So Lyme is nice. Some people call it limes with an apostrophe S. Lyme is never possessive and never plural. Although there is an attempt to possess Lyme by one full professor at Harvard who would like to have it as his personal property and pet. But Lyme is never possessive, and Lyme is never plural. It's Lyme, and it probably should now go to be Borrelia. That's short, sweet, it covers the Miyamotoi, it covers all the species, it covers around the world. That's the way to go. Call it what it is, Borreliosis. And then there's a whole politics, because Lyme is a hot button. You mention Lyme, and then right away you go to the CDC website, and you see all the rules. And some of the rules are okay, and some of the rules are not so okay. Take Lyme out of the equation, and people can visit the website all they want to, but we're going to talk about borreliosis from this point on. So we'll take all the politics out of the equation, because the CDC doesn't have a borreliosis website with a set of rules. They have a Lyme website with a set of rules. So let them have their headache, their knee joint, their heart, right, and their skin, and be happy with that, and be happy with short-term antibiotic therapy. Let them be happy with that. And that works for some people. And let the rest of us have the opportunity for chronic infection with long-term antibiotics and unheard of complications from the 80s and international distribution around the world, and no Lyme. Just call it borreliosis. The chromosome, which is about 1 million bases, and then the 21 plasmids, which are called mini chromosomes, which travel with the big chromosome. So it's clear that each of those have different DNA functions. The flagellae are coded for on the big chromosome, all right? Some of the outer proteins, many of them, are coded for on the mini chromosomes, or the plasmids. So they do have a function. There's also redundancy. The structure of many of the plasmids is such that there are zones within these plasmids that resemble other plasmids. There are circular plasmids and there are linear plasmids, and there are DNA repeats if you study the structure of the DNA of the plasmids, so that there's some redundancy, there's some backup. It's like a backup on your computer. And the plasmids are also potential targets for the energy that causes the flux, which is the changeability of the Borrelia over time. So the DNA in the plasmids is more likely to either change or to be modified, or even to drop out and drop off as the infection progresses in the body. Some infections are remarkable for loss of plasmids. Maintaining the strains of the bug in the lab is associated with loss of plasmids. Some of the plasmids are absolutely essential for infectivity. So if you lose a certain plasmid, the bug that you have with that lost plasmid will not be able to infect anything. So plasmids have a legitimate role. It's a diverse role. It's an important role. It's involved in the fluxing of the DNA. There are many chromosomes. They are able to exchange information with other plasmids in the big cylinder of the spiral, and maybe even exchange information with parts of the chromosome, which is much more stable. So that's really what plasmids are all about. And 21 is the number that we think about. Some of them have 19, some of them have fewer, but plasmids are mini chromosomes. We have continuing medical education as a requirement for licensure. Your medical degree will get you into the opportunity to go into a residency, which will then get you the opportunity to pass an examination, and then that examination, when passed and other things in place, will enable you to get a medical license to practice in a state. States require that in order to maintain your license, you must maintain your education by continuing to learn and by documenting that continuing learning, and we call it CME, or continuing medical education. If you don't spend the time and the money and you don't get the right number of credits, in some states you will lose your ability to write prescriptions and to see patients and have a medical license. And that's the way it should be, because medicine is a privilege. It's a privilege to see patients. It's a privilege to write prescriptions for patients. It's a privilege to help people, to solve problems. And Lyme disease is hard. And the Lyme disease skin reaction is not just a bullseye. And if you diagnose only bullseyes, you're doing Lyme malpractice, because you're missing all of the other erythemas, the redness of the skin. You're missing the other 16 types of erythemas that are really also just as good as a bullseye. If you're a bullseye only person, I hate to say it, you're a CDC person, because the CDC has the bullseye rash as the example of what Lyme disease is in the skin. And that's just the beginning. That's Lyme disease 101. That's kindergarten Lyme disease. And that's a great disservice to not reflect the fact that it is much more complicated than that, and that it has many more wrinkles, and there are always new angles coming along. Medicine is hard. I routinely got 200 credits every year, and I did a lot of traveling. And I didn't skip out to play golf in the afternoon. I stayed from 9 o'clock in the morning till 10 o'clock at night if the conference was on, from 9 o'clock in the morning till 10 o'clock at night. And my poor wife was a conference widow, because I wasn't there to have dinner with her. Now, maybe that's overkill. Maybe not. Maybe that's what it takes to keep up. We talked about the globalization of Lyme disease. We talked about European strains that can't be picked up with US testing, and we've talked about people moving, vacationing, military service, living in environments where you acquire the infection and then moving to another environment for more permanent residence where Lyme disease is not well known, or physicians are not seeing very many cases of Lyme disease. For those particular situations, then, I think the mandate is clear, and that is that if you have a condition which may be Lyme disease, and it may have been acquired in a geography which is distant from where you are now living, and you are living in a geography where not many patients with Lyme disease are being seen or diagnosed or handled by the local medical community, it might be in your best interest to go back to the community where you acquired the infection. So let's say you were camping in Germany, and you are military service in Germany, and you're living in the trenches, and you got infected with a European strain. And you come back here, you have trouble, you think it might be. So it might be the best plan to go back to the country of German Republic. And one of my good friends, Dr. Armin Schwarzbach, is a member of the German Borreliosis Society. He operates one of the many clinics that is devoted to treating patients who come from around the world to see him because they have European strains, and they need to have proper care and treatment. If you are living in the United States and you acquired your infection in Martha's Vineyard and you're now living in Arizona, it might be good for you to go back to get some medical attention in the state of Massachusetts, where they see a lot of Lyme disease and have some familiarity with babesiosis and with tularemia, both of which exist in Martha's Vineyard. And there was great concern when you mentioned rich resort communities and mentioned that they are hotspots for Lyme disease. The Hamptons are an example of that. The Martha's Vineyard and Nantucket are examples of that. Public commerce has not been dented or reduced at all by calling attention to a Lyme problem in a rich resort area. But it shouldn't be a pitfall for anybody who seeks care in going back to a geography where they may have acquired the infection, because that's where you might get the best chance for correct diagnosis and treatment. Then that can be continued with instructions when you go back to your home state or your home area. So that's a resource that people don't take advantage of. I advise people in England regularly, because the National Health Service in England is very, very conservative. And they have signs in the offices of some doctors in England that says, if you think you have Lyme disease, go elsewhere. And so the patients are not even allowed to register. And so those people contact me, and I tell them to get on a plane and take a ride to Germany, and you'll get diagnosed and cared for if you do have a Borrelia condition. So travel to the proper area may be the difference between success and failure in adequate treatment, adequate diagnosis. People who have been treated with what we call pulsed antibiotic therapy seem to do better than people who are not given a rest period. A pulse program means that you get, for 1 week, antibiotics, then you take a week off, you rest, you take some probiotics to rebuild the bacteria that were killed off by the antibiotics, and you reconstitute your GI tract. Then you get another pulse of antibiotics, and then it goes, on, off, on, off, on, off. And progress is measured over time, and then we'll see how patients do. You don't always get the same antibiotic in a pulse period. Sometimes they'll rotate them, and they'll have a pulse antibiotic A, and then a pulse antibiotic B, and then various programs. Before Dr. Costerton passed away, in one of the last interviews and the last seminars that he gave, he was very excited about two new things that were on the horizon that he thought would bear fruit. One of them was this new idea of nanotube communications between various biofilm communities like telephone wires to connect and help with communities. And the other was the use of electromagnetic energy to bust biofilms. And I haven't seen the articles which are the basis for this, but Dr. Costerton was excited by it. And it was not just any old electromagnetic energy, it was either ultrasonic energy of a certain frequency and a certain power, certain wattage, or other types of electromagnetic energy of a certain frequency and a certain voltage over a certain amount of time. I don't know the details of it, but I know that if Bill Costerton was interested in that line of therapy, I'm interested in looking further at it because I don't know very much about it. And it is not in any way the Rife machine. It's a much more powerful electromagnetic thing that he was talking about in connection with busting up biofilms. Biofilms can be fixed, which means they're stuck to a surface. Or biofilms may be floating, and they're equally real. And Borrelia has the capability of doing both floating and fixed. And one of the things that Dr. Steer never realized was that heart valve infections, where something sticks to a heart valve and destroys it, and it creates a lump called a vegetation. It's called endocarditis. It's inside the heart, inflammation of the heart valves. Well, now there are 2 reports from Europe again, of Borrelia afzalii causing human endocarditis and Borrelia bissetii causing human endocarditis, both proven with DNA analysis and with the highest level of scientific precision to prove that the bugs on the diseased valve were Borrelia. One was afzalii, the European, and the other was bissetii, the Czech strain of Borrelia burgdorferi. I'm sure other strains will follow. We have what we call in infectious disease culture positive endocarditis, which means the bugs will grow in the laboratory in a test tube. Now, what did we say about biofilms and their behavior when you put them into a microbiology laboratory test tube? Biofilm infections will not grow ever in a test tube in a microbiology laboratory. So, if we have a biofilm infection, and endocarditis is always a biofilm infection, and if we have a biofilm infection due to Borrelia, and you send that to the ordinary microbiology laboratory, you'll come up with 0 because it won't grow. Biofilm colonies do not grow in microbiology solid plates, microbiology liquid broths, or microbiology slants. They require special tools to diagnose and to detect. So you need a biofilm approach for a biofilm infection. And heart valves now are one of the new arena, never dreamed of by Dr. Steer in 1980, manifestations of Lyme disease. Complications from endocarditis. Part of the vegetation breaks off and goes up through the circulation to the neck and causes a stroke. Okay? Breaks off and goes through the body and causes injury in the liver or in the kidney. All right? So pieces of the community of a biofilm can break off, travel through the blood, and set up in a new area distant from where they started and cause all sorts of havoc. So you don't want to have it to metastasize like cancer metastasizes. You don't want biofilms spreading. You don't want them to metastasize. You want them to be contained and hopefully eradicated. Unfortunately, at inception, floating biofilms are already detached. So that's one of the problems with Borrelia, is that they do floating biofilms in addition to fixed biofilms. I'm happy to help. Thank you.